All right, so a little bit about me. I grew up in New York. I'm a graduate of the University of Chicago for undergrad, medical school, and residency. I completed a fellowship in hip and knee replacement in San Francisco. I enjoy hiking, skiing, and cooking. Overall, just enjoy outdoor activities. So I've always been very active throughout life. I rode in college. I played a lot of basketball. I've also done numerous marathons. And that's part of what motivated me to go into orthopedics because I understand the value and the need to be active and how it can seriously affect someone's well-being mentally and physically to lose the ability to be active. I was interested in joint replacement because the intersection of the tremendous quality of life impact one can have on patients in this field and the use of technology was something that really interested me. So for my practice locations, I work out of the Camelier building as well as Shady Grove. I operate out of Suburban Hospital and also outpatient surgical centers in the area. So my philosophy about this is that orthopedic surgery and joint replacement are constantly evolving. It's not a one-size-fits-all approach, so I strive to treat patients in accordance with the most modern and up-to-date principles that one can find. And practicing medicine and helping patients is really a lifelong journey and privilege. So an overview of the talk, I'm going to go through non-operative treatments, outpatient surgery, anesthesia and pain control facets, the improved biomaterials that we're seeing with knee replacements, robotic arm assisted surgery, and also our improved understanding of knee biomechanics. So first of all, what is arthritis? So arthritis is wear and tear of the cartilage surface at the joint articulation that can lead to inflammation, swelling, pain, and mechanical symptoms like clicking, popping, catching, or giving way. There are multiple causes of arthritis, including osteoarthritis, which is garden variety wear and tear arthritis, post-traumatic arthritis from a previous fracture or ligamentous injury, and then also inflammatory arthritis, such as rheumatoid or lupus. In terms of non-operative treatments available, so going down in order from the most conservative to the most or more intensive options. So one can rest the affected joint, activity modification as far as transitioning from higher impact activity to lower impact activity, avoiding stairs, kneeling, squatting, or activities that kind of put more pressure on the knee. Anti-inflammatory medications, weight loss, and muscle strengthening are all very important principles. The clear difficulty with rest as it relates to the lower extremities joints is that one cannot fully sort of offload your knee or your hip as effectively as one can for, like, say, your elbow or shoulder. You can choose not to use your arm, put it in a sling, and use your other arm. But for our legs, we're constantly putting weight on them, and so it's hard to fully rest an injury once it's occurred. So physical therapy would be next. So again, as it relates to muscle strengthening, there's a lot of stuff out there that keeping the muscles strong keeps the joint stable and prevents further injury and prevents arthritis progression. Bracing. So as far as bracing is concerned, it's more of a proprioceptive feedback for your body to not twist the joint or overuse it, but it's also known that overuse of a brace can lead to muscle weakness and atrophy. So I tell people, if you have arthritis, you use a brace, you only want to use it when you're hiking or doing more vigorous physical activity, and not use it all the time or become dependent on it. And then as far as injections, there are multiple different types. There's corticosteroid, so that would be basically taking anti-inflammatory medication and delivering it straight to the joint to reduce the inflammation that's associated with arthritis and to reduce the swelling and the pain. People think of this as like panacea. It's not solving the issue, but in fact, reducing the inflammation does slow down arthritis progression. The inflammation does cause cartilage damage concomitantly. On the other hand, we tell people that you don't want to overdo it with corticosteroid injections, because by doing so, that can accelerate weakening of the underlying bone and the surrounding ligaments, etc. Other injections would be hyaluronic acid, which is a gel or lubricant, delivers lubrication to the cartilage and increases or improves the nutritional environment for the cartilage to help it also reduce inflammation. And then platelet-rich plasma, which is a therapy that's not insurance covered, but this is taking your own blood, taking some of the growth factors from there and injecting it to the joint to also help the cartilage reduce inflammation and some regeneration to occur. All right, so once non-operative treatments have been explored, moving on to surgical treatments. So then this falls into two broad buckets of joint preserving procedures, such as arthroscopy, cartilage or meniscus transplantation. So these therapies really only work if there's an isolated cartilage defect, like a small, let's say, pothole of cartilage, as depicted in the upper right. It does not slow down arthritis when there is diffuse cartilage damage throughout the joint, as is pictured in the lower right. And then cartilage and meniscus transplantation is effective sort of in younger athletes or patients where the healing parameters are favorable. But those types of procedures are, again, also only effective when there is less arthritis in play and it's not diffusely affecting the joint yet. So when there is diffuse arthritis, the joint replacement possibilities would consist of partial knee replacement, which is depicted in the lower middle left, and a total knee replacement, which is in this part of the picture. Osteotomy was previously considered a option for relieving the contact stresses in joints to kind of shift the stress from one part of the joint to another, but this is less commonly performed nowadays with the success of our joint replacement procedures. So what is a partial replacement or versus a total knee replacement? So again, going back to the picture in the middle there, so the one on the left, there is a partial knee replacement. So what that entails is the knee consists of three compartments, three distinctive compartments. There's the medial compartment or the inner, the lateral compartment or the outer, and the patellofemoral compartment, the part under the kneecap. If someone's arthritis is only confined to one compartment, then they may be eligible for a partial replacement of the joint versus doing the whole thing. And this slide is going over the pros and cons. So partial knee upsides is that it's a smaller surgery and a smaller incision. It's a relatively quicker recovery, about 6 weeks, 6 to 8 weeks. It feels more like someone's God-given knee or the knee that they were born with because the ACL and the PCL ligaments in the middle of the knee are preserved. And there's a lower risk of complications such as infection or blood clot because it's a smaller surgery. The downsides or limitations of a partial knee is that if you only replace the one part of the knee, there is always the possibility of arthritis setting in the other parts of the knee that have not been replaced. So there's the possibility of needing a full knee replacement in the future. Also, this procedure, the partial knee replacement, is not useful for inflammatory or rheumatoid conditions because that afflicts the whole joint and not just one part of it. And it also can't be used when the arthritis is causing a significant deformity, as in if the leg is bowed or won't straighten fully, because in that case, partial knee replacement can't solve that problem.
Dr. Luke,
Yes.
do you see at the top right or for the Gemini, can you close that out?
Oh, sorry. There you go. All right.
Perfect, thank you.
So who should consider surgery? So basically, patients who have end-stage arthritis, where it's bone on bone or there's no cartilage remaining. If there's pain affecting your quality of life, affecting activities of daily living, and you've tried and failed conservative treatments, pain is affecting sleep, and if someone is in otherwise good health. These are all the factors that would go into consideration for knee surgery. Although it can help people stay engaged in sports such as golf, tennis, pickleball, etc., it should not be seen as a method to improve someone's playing ability. So there's been studies which showed that handicap diminishes by less than one stroke after a knee replacement. So unfortunately, your golf will stay about the same, but you'll play with less pain and you'll be able to walk the course more effectively. All right, so moving on. So outpatient surgery. So really, COVID accelerated the adoption of outpatient joint replacement surgery in the face of nationwide hospital shutdowns. So 10 years ago, when I was finishing training, a lot of these joint surgeries had a 2 to 3 day hospital stay. Patients were only walking the next day. There were Foley catheters, surgical drains. People were, a lot of people went to rehab facilities and also received Coumadin anticoagulation. So today, now it's a 0 or 1 day hospitalization, meaning same day surgery or leaving the next day. You're up and walking the same day. There's no Foley catheter, no drainage catheter, and for the most part, people are given baby aspirin. And basically, the experience even before COVID, but particularly when hospitals were not available for this, showed that outpatient surgery is a safe and effective recovery process, and early mobilization leads to lower complications and better outcomes. So less than 10 years ago, again, the goalposts were quite different. Even among patients needing to go to rehab facility, about half of them, by Medicare mandate, people have to stay 3 days in order to qualify for rehab. But even then, people, over half of people would not need to medically stay for that reason. It was a purely administrative issue. So this is a paper that I was a co-author on. So talking about the 72-hour Medicare mandate after total joint arthroplasty. And basically what we found in that was that between days 2 and 3, people had same vital signs, other blood tests. And so people were staying in the hospital and being subjected to basically unnecessary testing and could have otherwise been already discharged from the hospital. Why is going home better? So basically, being in your own environs does spur you to do more things for yourself, going to the bathroom instead of using, say, a bedpan, commode, or a urinal. You have to go walk to the refrigerator or go outside the house to check the mail, etc. So all of these things, which a patient is not doing for themselves if they're staying in the hospital, basically increases their mobility, reduces the risk of blood clot, constipation, pneumonia. Right. So by basically going back to your home environment and doing more things, it gets your circulation going, it gets the muscles moving, which is all good. Familiar surroundings also lead to reduced risk of delirium. In a hospital, people don't get as good sleep. You wake up in the middle of the night with people checking your vital signs, etc., and in an unfamiliar environment, so there's a higher chance of delirium. The food in hospitals is not great, and so being with food that you are familiar with is good for one's bowel motility, and there's just fewer germs as far as hospital acquired germs. And then blood draws and dressing changes with today's streamlined processes are largely unnecessary and just extra stress for no reason. Then there's having outpatient surgery at the hospital, meaning you have surgery at the hospital and still go home the same day from there, or doing it purely at an ambulatory surgical center, which is better and which should a patient choose. So from that standpoint, medical comorbidities would play a role in deciding that. So if a patient has cardiopulmonary issues, liver, kidney, or coagulation disorders that require closer monitoring on the hospital, that certainly would be a good reason to have hospital-based surgery. If it's a revision or complex surgery, or meaning a redo surgery, or if the anatomy is complicated by any specific circumstances. If someone's preoperative functional mobility wasn't great, meaning you couldn't walk more than a few feet or can't go up and down the stairs, and lastly, if there's a lack of a safe rehabilitation environment at home, these would be reasons to be at the hospital instead of the ambulatory center. Now, in the absence of those aforementioned factors, if a patient is a medical candidate to have surgery at the ambulatory center, which is better? So I would assure you 100% the surgery is performed the exact same way in both settings. I mean, I don't do one thing at the hospital versus another thing at the center. The surgery ends up being the exact same. The hospital offers more support for a variety of cases, such as heart surgery, trauma, transplants. So although joint replacement pathways and protocols are in place at the hospital, it's not fully streamlined toward a joint replacement patient, meaning the hospital is a busy place, and in the recovery room there will be 20 or 30 patients, whereas if you're at the ambulatory center, there's 2 or 3 patients and they're all getting the same thing. So from that standpoint, if you have it at the hospital, you may need to wait longer for a PT or to be discharged home. So the whole process may be like an all-day affair versus at an ambulatory center being a 5 or 6 hour affair for the whole process from getting ready, having the surgery, recovering, and then being out the door. So from that standpoint, if someone is a good medical candidate and has done their homework as far as preparations of their home environment, et cetera, really the ambulatory center offers unique advantages. Part of what has made this possible to do the outpatient surgery is improved surgical techniques. So using smaller incisions, improved instruments, and smaller implants, a shorter operative time, typically an hour to an hour and a half operation, and less blood loss. So we give drugs to reduce bleeding. We use radiofrequency or bipolar electrocautery, and transfusions have been rendered unnecessary. So these improved surgical techniques have made it feasible to consider this as an outpatient surgery. Talking about surgical techniques, so there are various surgical approaches for knee replacement. So going from left to right, so this is looking at your knee from the front, and at the top is your quadriceps, and below is the lower leg, and in the middle of each little diagram is a kneecap. So going from left to right, you have the most traditional knee replacement approach to more sort of muscle sparing approaches. So on the left side, there's the medial parapatellar, meaning this is an approach that goes into the quadriceps tendon. And while this was used forever and ever to do knee replacement, people take longer to regain their quadriceps function and control. And so that leads to longer recovery. The approach that we use over here, by and large, at OrthoBethesda is the middle, this mid-vastus. It's going in the direction of the fibers of the vastus medialis, or the inner part of your quadriceps muscle. And basically, by going along the direction of the fibers, you're splaying the muscle apart. You're not cutting the muscle, and you're also not cutting the tendon. And that leads to a quicker regaining of quadriceps function, the ability to do a straight leg raise, and be off the walker in pain. Furthest to the right, there's a subvastus approach. This is a newer approach, and the reason that we have not adopted here is that it's less visualization, and it's also not suitable to every knee. There's patients with more deformity or more difficult anatomy where doing that would potentially lead to malpositioning of implants and whatnot. So while we want to provide a less invasive approach, the mid-vastus, or the middle one, is a nice balance between being less invasive, so having a quicker recovery, but also delivering a finished knee replacement that will hold up for the long haul and have the optimal alignment and component position. So if you're thinking about all of this and outpatient surgery and whatnot, if this is right for you, just know you're not alone. Talk to others who've gone through the process. There's extensive educational information provided beforehand. We also call postoperatively to check in. And there's always a physician and PA available 24/7 for emergency questions. So yeah, the most helpful thing is talking to other people who've been through the process. All right, so next broad category of newer developments, meaning anesthesia. So the surgery for a knee replacement can be done either with spinal anesthesia or general anesthesia. Spinal anesthesia is really not a new thing. It's been around for a long time. Think of epidurals for childbirth. So that's where the patient is numbed from the waist down, and medication is given just to help the patient take a nap. There's no breathing tube. You don't have to get a lot of opioids or narcotics. And so people wake up from this very quickly and normally because there's not the effects of opioids given during surgery. On the other hand, general anesthesia is where medications are used to provide sedation, but because the medication is given intravenously, a breathing tube has to be used to help the patient breathe. So both methods are safe, effective, and employed routinely. The only reason that spinal anesthesia is sort of newer to this is that basically uh, again the streamlining of the process for knee surgery, the fact that it's routine, minimal blood loss, and a very predictable time length makes it eligible for spinal anesthesia. If the surgery took longer or had unpredictable blood loss, then it wouldn't be feasible. Now, what are the benefits of spinal anesthesia? So again, it avoids opioids intra and postoperatively, so there's less postoperative nausea. And then there could also be less cognitive side effects. So there's been studies which show that basically having general anesthesia, either people who are really, really young, such as babies, or people who are older, it can cause effects on the brain and basically can cause some lingering postoperative cognitive dysfunction. So this is still being studied. It's not fully clear, but there's some associations. So when it's possible, anesthesiologists and surgeons alike will discuss giving spinal anesthesia as a preferred method. And so pain control right after surgery. We have had an intense focus on reducing opioid use in the face of the epidemic nationally. So to combat this, there's a preoperative pain cocktail given right before surgery. The spinal anesthesia is given, and then there's a periarticular injection of the joint around at the time of surgery. We also give nerve blocks, which regionally deaden the nerves that affect pain. So, and finally, by giving a regimen of anti-inflammatories, Tylenol, and the nerve block, this can effectively reduce opioid consumption to a minimal level. Back in residency, I did this study looking at adductor canal block, which is a type of nerve block used for knee replacement surgery. And basically, this has now become standard nationally. The only difference being that back in residency, again, patients were staying a couple of days in the hospital. So we actually placed a pain control catheter to deliver sort of a continuous nerve block, but nowadays it's a single shot. They numb the nerve using a ultrasound device to guide the needle to the right place. The local anesthetic is given, and then that lasts 12 hours to a day. Studies have looked at this and shown that delaying the onset of pain until after the acute injury is over is beneficial, not just in the short term, but also over the long term. Basically, by not tripping the nerves initially, it can decrease the possibility of chronic pain weeks or months down the road as well. All right, so next moving on to actually the procedure itself. So one of the areas that has made great headway is improved biomaterials for knee replacement. So in the last few decades, newer porous metals and titanium have been developed to support biologic fixation of implants. So what is meant by that? So traditionally, knee replacements have always been cemented or glued to the bone. So the picture on the right is depicting traditional knee replacement that is glued into the bone. That provides immediate secure fixation, and it's been the gold standard, and it's been done that way for decades. What's the downside of this? Well, the glue, it's a grout. It does not respond to your daily stress of using the knee. So invariably over time, over the tens of thousands of steps per day, or hundreds of thousands of steps and millions in a year, you will invariably break down the glue, and that will lead to loosening and is one of the determinants of the longevity of knee replacement. So traditionally, people quote 15 to 20 years with a knee replacement that's done well. And part of that is the durability of this glue. Meanwhile, the newer technology that's been developed is cementless fixation, which offers a durable bond and that regenerates in response to the body's stress. So when you're walking on it, the bone cells are actually attaching to the metal stronger and then form a stronger bond, and that will, in essence, never loosen unless something happens like breaking the bone or something like that. So this porous metal for cementless arthroplasty has been around for a while now in hip replacements, but it is only now becoming more prevalent for knees because the knee is more delicate joint mechanically speaking, and so we'll discuss that later in terms of the biomechanics. But due to recent enhancements in manufacturing processes like 3D printing, this has enabled this fixation method to become reliable with very, very minimal early sort of failure. There's also improved plastics. So newer generation plastic, the plastic cushion that goes into a knee replacement between the two metal caps on the end of each bone. So that plastic cushion is also responsible for the longevity of your knee replacement. So older implants, the plastic was not as durable and shed plastic particles, which would cause inflammation and then gradually loosening of the joint. But contemporary knee replacement is done with highly cross-linked plastic, meaning the plastic is radiated and that makes the plastic particles have a stronger bond together. And that offers greater resistance to wear and makes things last even longer. All right, so moving on. So robotic-assisted surgery. So there's numerous robotic platforms available to help assist knee replacement surgery. And people think robotic surgery, they often think of the Da Vinci and for prostate surgery or cardiac surgery. This concept of a robotic arm helping with surgery exists in joint replacement as well. And so why is it useful? So basically, this is a technology that helps enable preoperative planning and more accurate component positioning. It's a collaborative robotics, meaning the robot is not doing surgery sort of unsupervised. The surgeon remains in charge of the procedure. It's only to help the surgeon deliver and perform the surgery more accurately. The reason for using it is that every individual has slightly different anatomy. So the angular alignment of the bones and the joint and the tension of the ligaments is different from one person to the next. So from that standpoint, if we did the same knee replacement for everybody, while it would be very successful for one person, it wouldn't have quite the same effect on the next person. So for the robot, the robot precisely registers the location of the patient's bone and joint in space, and then also helps to measure the soft tissue tension. So on the bottom right, this is an example of a robotic surgery planning screen, and you see how it says on the two sides of the joint, one side has 18.5 millimeters of space and the other side has 19.5. So by using the robotic technology, you can really dial in and make the process accurate to the half millimeter and millimeter, which really aids in the execution of a very precise surgery. So yeah, I talked about how traditional knee replacement is more one size fits all. You cut based off the mechanical axes and put this in 6 degrees and the other part perpendicular to the bone. Well, with a robotic assistance, you can make it much more configured to the patient's own bone. And the reason I really strongly believe in this is that in the robotic assisted surgery is that in the general population there's about 10 to 20% of knee replacement patients who are not fully satisfied with their procedure. They still have some pain or lingering after effects. And basically, the aim of using this ancillary technology is to augment our capability as a surgeon and to make what we do more precise, to reduce that number to less than the general population, but single digits certainly, but hopefully less than even 5%. So some studies show that robotics reduce outliers in component position, leads to less postoperative pain and overall greater patient satisfaction. All right, finally, want to touch on our improved understanding of knee biomechanics and also how that relates to knee surgery. So it was previously thought that the knee was a simple hinge joint, meaning you straighten your leg, which is extended, and you flex it. And so, and in that simple paradigm, knee replacement would replicate a simple hinge, sort of a simple hinge device. But it turns out that there's movement in 3 planes. So there's the straightening and bending. There's also what we call rollback of the femur relative to the tibia, meaning that the femur or thigh bone slides backwards, or conversely, the shin bone slides forwards when you're moving. And then finally, there's some rotation as well, meaning your foot actually goes from turning inward to outward as your knee bends as well. So based on this, again, the traditional knee replacement pictured in the upper right being more of like a simple hinge. The inner and the outer, or the medial and lateral sides, appear fairly symmetrical, or sort of basically the prosthesis treats those 2 parts of the joint the same way. That's not how someone's actual knee works. So in modern implants, they take this into account, and we've developed what's called a medial pivot design, meaning that the inner part of the knee remains fixed during flexion extension, and the outer part of the knee, the lateral side, translates. So that replicates the rotational component. It also means that the knee doesn't click or clunk as much as with the previous older generation implants, which had this plastic post. So there's less of a mechanical feeling to the knee. It feels more like someone's God-given knee, and this can ultimately improve patient satisfaction. Okay, so we reached the end. So in conclusion, joint replacement surgery has come a long way from when I started. It was about 10 years ago, and things continue to evolve. We strive to personalize the experience for you and to ensure a successful recovery and outcome, and definitely talk to others who've gone through it before. So I think we're coming in just at 40-ish minutes. So now I'll take any questions. This is my contact info. And again, thank you for attending the talk. Okay, so now I'm going to stop sharing the screen and then go to the chat. Okay. All right, I'm going to go in chronological order. All right. So, yeah, so our first question is, do you do ACL and PCL retaining TKA if those ligaments are healthy and intact? And what is your view of the conformist custom implant? So in terms of a total knee replacement, the ACL is by and large always removed. There is one implant that retains the ACL, but it is not widely done. That procedure is almost like getting two partial knee replacements at the same time instead of one full knee replacement. And so there's downsides to retaining the ACL because you don't have the same footprint of the tibia for fixation. The PCL can be retained and is often retained during surgery. It depends on if the PCL is healthy and intact. And so that we most of the time leave in place. As far as the conformist custom implant, this was in vogue also 5 to 10 years back as people were trying to strive for new solutions. I believe one of my partners has done a lot of these, but he has also switched to robotics as a more efficient way to basically deliver a customized and personalized knee replacement. Basically, with the conformist, you would have to scan your knee and then select the sizes and have everything sort of planned beforehand. But with the robotics, we can basically do all the planning and sort of execution at the time of the procedure. Okay, one person said, "Hi, I'm definitely interested in hearing about hip replacements. I certainly would be happy to answer a specific question, but I don't have a way to like cover the whole swath of everything now. But if you type a specific question about hip replacement, I'll be happy to get to it." Okay, next question. I'm 67 years old. I have pinched nerve in my left knee at about the 11 o'clock point. I have no issues with strength, climbing stairs, etc. The great pain comes from when I kneel on it or twist in certain ways. Feels slightly inflamed. What can be done to address this? Well, there's a pinched nerve, so that could be a neuroma, and then there's also pain with kneeling, which could be the kneecap, twisting in certain ways, could be a meniscus issue or cartilage issue. It's sort of a general question, but in terms of what can be done to address it, basically, if you've looked at the conservative treatment options that I previously addressed, then be happy to image the knee and see exactly what's going on to answer your question more fully. Okay, I came into your offices and saw Dr. Canova with knee pain. After x-rays, it was determined that my knee was okay, but my hip needed replacement. That is now scheduled. My question is, could I still be having ligament or tendon issues causing my knee pain that was not picked up on an x-ray? If so, can that be determined and would it be appropriate to schedule that repair at the same time? Yeah, so I believe you're getting the appropriate treatment. Oftentimes, knee pain is referred from the hip based on the way the nerves work in the body. So the sensory nerves travel past the hip to get to the knee, and also due to altered gait from hip arthritis, when someone experiences knee pain, it could be coming from the hip. So I have no doubt that Dr. Canova has fully worked this up and is doing the appropriate procedure. Now, you'll see once you have the hip surgery, if your pain relief is fully relieved, or if you still have any lingering symptoms afterwards in your knee. And my bet is that it will be fully relieved, but if you do still have any lingering knee problems, it will be milder and less intense than before, and then it could be addressed non-surgically. Okay. All right. Okay, sorry. Again, someone was hoping to hear about hip replacements. I would definitely like to answer questions about that. And I'm sorry again to make the talk more in depth on the knee side. And for time reasons, we made it mostly on the knee. But I'd be happy to give a hip talk as well, or talk to you individually and address questions later. So can you? Okay. What type of material advances have happened with partial or full knee replacement? If partial done or full and a full is needed later, are the parts associated with the partial disposed of or still used? Now, that's a good question. So, material advances both in partial and full. There's the biologic fixation. So, in a partial knee replacement, you can do the same cement-less approach and technique as with a full knee replacement, meaning that you can get biologic fixation. Um, Whenever I do a partial, I do tell people that the hope is that this is your one and done procedure. I think it's a defeatist mentality to say the partial is only being done to buy you time to get to a total. That's never what we're really thinking. So when you do a partial and it's done well, that should last you indefinitely. However, if and the studies show it's less than 10% of people who have a partial that eventually need a full. So if that's the case, and that's years later, you can consider whether you add another partial to that partial or you just exchange it to a full. In most cases, people would, at that point, if there are two out of the three compartments involved, most people would just go ahead and do the full replacement rather than chance another partial and then possibly still have a third compartment involved. So yeah, the partial parts would be disposed in that scenario. Okay, next question. Here's my question. As an active CEO, I can't afford to slow down, but I've been noticing that my knee seems to be deteriorating. I want to stay ahead of this and not wait until it becomes a bone-on-bone situation. From your experience, could a gel or visco supplementation injection help protect the joint and extend its healthy function before things reach that stage? Very interested in preventive next-level strategies rather than reactive fixes. Yeah, so preventive strategies definitely work on muscle strength and the stability of the joint, hinge exercises, various squats and lunges to strengthen the muscles around the joint. The key is to exercise in a way that doesn't cause more pain or inflammation. And then visco supplementation can be used to boost the lubrication and nutrition to the cartilage. And so that's definitely a viable strategy for someone who can't deal with it surgically for the time being. All right, if an MRI has been done and shows both some type of minor arthritis as medial meniscus wear, is it possible to go in and just assuming a medial repair, debriding, and a debridement, and then decide on the fly whether a partial knee is better route, or should that just be decided ahead of surgery? So your question is whether arthroscopy would be so if a surgery would be between an arthroscopic debridement or a partial knee replacement. Usually uh, that decision is made beforehand because those two are quite different procedures. So arthroscopy is a 2-week turnaround recovery. You're using crutches for the first couple of days and then back to pretty much normal. Whereas a partial knee replacement does involve a period of physical therapy and 6 to 8 weeks of recovery. Sometimes we run into a situation where the decision is between a partial and a full, and that can be decided intraoperatively if the arthritis looks worse than on the imaging. But I've also not really had to make that a game time decision either. So really, I think the decision should be done well ahead of surgery, and usually the imaging, the MRI would be able to um, address that. What is the likely time frame after a hip replacement for full recovery? How long could we expect a new hip to work well? So for a full recovery, meaning back to normal daily activities and walking around and not using any ambulatory aid, probably 4 to 6 weeks. And people are walking and uh, getting out of the house even before that. For driving, for a left leg procedure, it would be 2 weeks. And then for the right side, it would be 3 to 4 weeks, just based on your use of the leg as a driving leg. For how long we could expect a new hip to work depends on your age and activity level, but the newer generation plastics have shown very little wear at 25 plus years. So they should be expected to last indefinitely, basically, barring extreme levels of activity like marathon running. So we do tell people to not run for the main form of exercise after a joint replacement, because that can accelerate wear. You can run short distances and also do running interspersed with other activities, but running as a main form of exercise can reduce the longevity of the joint. All right, so can you do cementless if you have osteoporosis? Yeah, so it depends on the degree of osteoporosis, but generally speaking, if there is significant osteoporosis, that means that there's a weakening of the bone structure that supports the knee replacement implant. And in that case, there's a higher chance of a cementless part subsiding or even causing a fracture. And so that would be carefully scrutinized intraoperatively. And if the bone quality appears to be impacted, cement is very safe and effective. Particularly when we're talking about cementless, this technology is meant to extend the longevity or durability of the implant. So people who benefit from that, meaning people who are younger, more active, and meaning like someone who has a knee replacement in their 50s or early 60s, the osteoporosis does not tend to be an issue at that stage. Now, later on, if you needed a knee replacement done at 70 or 80 and above, then the longevity of a cemented implant works equally as well, and there's no downside to cementing, and there's potential downside to using cementless. All right, what are the brand names of some of these newer knee replacement products? Well, I've spoken about multiple things, and in terms of the actual knee replacements themselves, the Zimmer Persona is a relatively newer knee replacement. The DePuy Attune, but we don't have like a brand, preference from that standpoint. There's robotic platforms across all the manufacturers. So think of like car manufacturers, Ford, Chrysler, GM, etc. There's multiple implant companies. They all have their robotic systems. I'm not affiliated or paid by one brand or another, and don't have sort of that kind of relationship with them. But yeah, so as far as the names, there are newer lines of knee replacement. There are robotics, the Cori, the Velis, the Rosa, and these are all out there. How soon after you have one knee replacement should another one be done? I'm assuming this means you have bilateral, meaning both knees having arthritis. And so the answer to that question depends. It depends. So if both knees are severely affected and just doing the one doesn't get you back to a good functional level, then you could do the other one in a month, 6 weeks. or sometimes even sooner. I've done them as quickly as 2 weeks apart. If uh, they're if they're arthritic, but you're not in a hurry to get the second one done, you can have the one done, fully recover, and wait a year or so to do the next one. So it really depends if the second or other side is limiting your return to activity and the things you want to do. So if that's the case, it can be done 2 to 6 weeks or a couple of months later. But if one is not a limitation against the other, then wait as long as you want. How do avid golfers do with total knee? So I did have a slide where it illustrated the return to golf and handicaps. So people have shown that about 3 months for walking a 18-hole course and basically reduced pain. Visual analog scores decrease from 6 to 1 point something, and the handicap improves by less than 1. Yeah. All right. So if hip and knee replacements are both needed, which should be done first? In that case, most of the time people will be counseled to do the hip first, because not doing the hip can impact the recovery of the knee, but vice versa is not true. Not doing the knee replacement will not impede the recovery of the hip. Is knee joint replacement surgery ever overprescribed? What should you do if one surgeon says you need it and another says you don't, e.g. the arthritis isn't too bad? Well, over here we strive to be conservative and really only do it for people who truly need it. But I guess it depends on the quality of the two opinions you received. The great thing about OrthoBethesda, it's a strong practice, strong reputation, and people come see us for all manners of problems. And we're able to then only indicate people for surgery if they truly need it. So I mean, I guess, is someone trying to advise surgery because they're not busy enough? I don't know, but I would say to my group and practice, we do not feel it's overprescribed. So I guess it depends on the quality of the opinions, and if you want to seek a tiebreaker or get another opinion. As a 48-year-old woman with knee pain from early stages of arthritis, what should I be doing to delay knee replacement? So keeping the muscle strong, making sure you have plenty of vitamin D, healthy, balanced nutrition. What's good for the rest of your body is also good for your joints. So muscle strengthening, maintaining the stability of the joints, maintaining a healthy body weight. Those are the main things. There's no magic nutritional supplement, but minimizing the inflammation throughout the body is crucial as well. When will there be hip replacement segment aligned? We can have Myrna arrange that as soon as possible. Okay, so seeing a friend having knee replacement and going home, I know that pain management at home is definitely an issue, especially as opioids are more and more restricted. Said if she would have jumped out the window. Okay, that's not the general situation. I'm sorry to hear that. How can that be improved? Well, certainly we, want to evaluate if something was going on with her specific scenario that was unexpected or not norm. But there's the medication regimen that I described, nerve block, and all these modalities. But sometimes additional measures are thrown in, nerve medicines, muscle relaxants, and all you have to do is get in contact with your provider to see if something more is needed, and also to rule out if there's something going on that shouldn't be happening. Do you determine whether a total or partial replacement is needed before you start surgery? Yes. In uh, almost all cases, the determination is made beforehand. Are pain methods used for the knee, i.e., nerve blocks, the same as for the hip? So nerve blocks are not used so much for the hip because the hip, by and large, is a less painful procedure. You go between muscles. There's no muscle cutting whatsoever. And basically, nerve blocks have actually only been shown to slow down one's mobilization after a hip replacement. But some of the other modalities, such as injecting the joint and the multimodal pain regimen, um, those are done. Okay. So for total knee replacement, which manufacturer would you recommend? So I'm not agnostic to one versus the other. It really depends on your surgeon's comfortability with the brand, how much they've used it, and how comfortable they are with the instrumentation. DePuy, Stryker, Zimmer, Smith & Nephew, they all have excellent products with very good track records. And I've used multiple ones, and so there's no bias or industry relationship on my side. Is the recovery period the same as in the past implants? Well, no, the recovery has sped up with some of the techniques I've described. Okay, wonderful presentation, especially because of the detail on mechanics of the knee and surgical issues. What limitations will the knee have after replacement surgery? Can you address the infection risks? So yeah, limitations would really be with prolonged high impact activities such as running marathons. And if you do that, you are putting it at an increased risk for wear. People go back to tennis, golf, pickleball, etc. Kneeling can be an issue. So kneeling can be an issue for people even prior to knee replacement, as far as having the arthritis there. But kneeling with the artificial knee can feel weird. It's not a limitation per se. So I do allow people to do it, but I tell them they might have to use a cushion. Can you address the infection risks? So the infection risk after a primary knee replacement is overall less than 0.5%. And so it's exceedingly rare. It's affected by factors such as diabetes, smoking, or immune compromise, or obesity and malnutrition. So as long as someone is medically optimized, the diabetes is controlled, and they're not smoking, and any sort of medical issues are addressed, the infection risk is very, very low. There's always a post-operative infection risk as far as getting dental procedures or having an infection in other parts of the body that spread to an artificial joint. So the joint does not have its own immune system. But if your body's immune system is working well, then all that is needed is you have to be cognizant if you develop an infection in another part of your body. If you have a wound that gets infected, well, get on the proper antibiotics for that so it doesn't travel into your bloodstream. And as long as those infections of other body sites are addressed appropriately, then it shouldn't spread to the knee. How long before a patient can travel after knee replacement and play golf or tennis? So travel, so in the first month after surgery, you're at higher risk for blood clots. So discourage traveling as far as the airplane travel unless it's an emergency or something. And we give you blood thinners to reduce blood clot risk. Play golf, so you can start to do swings and driving range 6 to 8 weeks, and then return to full play in the 3 to 4 month range. Tennis would say about the same, with doubles being earlier than sort of singles tennis. What is the current science and your personal assessment of platelet-rich plasma therapy? So yeah, I mentioned it as a possible non-operative treatment, but my colleague, Dr. Gruner, is more equipped to sort of answer the nitty-gritty on that. I don't perform platelet-rich plasma. So I refer to him for patients who are potential candidates, and that means mild arthritis. If there's mild arthritis, meaning grade 1 or possibly 2 out of 4, then it can be a effective treatment option where sometimes doing a shot once a year can provide significant relief. But yeah, if you want to know more about this, Mark Gruner would be the person to go to. Are you doing hip replacements as much as knee replacements? Yeah, it's about 50-50 in practice for me. Is robotic also used on hip replacement? Robotics is actually not as commonly used on hip replacement because the benefit and the advantage is less sort of evident in that. The hip is a ball and socket joint. The mechanics of that are easier to replicate than the knee, which is like the presentation showed. It's more intricate. It's a millimeter here or 2 is much different. All right, so next question. Can you do a 23-hour stay to be monitored for complications, then sent home? And so, yeah, that is feasible. But basically, I would say, again, is this something that's necessary, or is this just a fear or anxiety that we can help you through? If someone has medical comorbidities and needs to stay over, then certainly we can arrange that. What concerns might a diabetic have when considering knee replacement surgery? So diabetic, 2 concerns. So the diabetes has to be long-term, well-controlled, meaning an A1C of less than 8, or preferably less than 7.5 or 7. That shows that their glucose has not been too high in the past 3 months. So good long-term control is correlated with lower infection risk, but also good perioperative control. So not letting the sugar spike in the weeks after surgery. So avoiding those spikes really diminishes the infection risk. How many patellofemoral partial knee replacements have you done? Which ligaments affected in this operation? How long can such a replacement be expected to last? I've done a lot of these. I don't know exactly the number. Certainly, full knee replacement is the most common, and then partial as far as the medial or lateral tibiofemoral joints, those are second most, and patellofemoral is sort of the least. And that's because of 2 things. Isolated patellofemoral disease is less common, but also if someone has strictly isolated patellofemoral arthritis, it's usually also something that is better tolerated, meaning that only affects people with stairs, and so stairs or getting up from a chair and walking longer distance. So basically, the symptomatology of patellofemoral arthritis can be better controlled in a lot of cases, and people actually don't notice it until it's later, until it's progressed to all the other compartments. So as far as patellofemoral, this is probably something that do like 5 of these a year or something, not like a large number like full knee replacement. Had issues with GI flare-ups after various medical procedures, even when the doctor and medical team are aware of my medical condition. What are the things I need to tell them to avoid a possible flare-up and potential surgical postoperative failure? I guess what type of GI flare-up is like an inflammatory condition, or like a GI tendency for GI bleeding, or so this issue can be worked up and addressed with a multidisciplinary kind of collaboration. I talk to other specialists, hematologists, rheumatologists, and I'd be happy to talk to GI as well to manage that, and come up with a plan for that. I have had one knee done and a year out. It has become to feel heavy and numb. That's unfortunate, but I'm not sure that's a question. I guess numbness after surgery is some numbness can happen because some of the skin nerves are cut. But as far as a feeling of heaviness, um, so as I said, there is that 10 to 20% in the general population, and here at OrthoBethesda it's a lot less, but we would be able to like look at and see what's going on with that exactly. What precautions are taken to prevent prosthetic joint infections? How prevalent are these infections? I've addressed that it's less than 0.5%, basically by doing the surgery quickly, efficiently, low blood loss, and not taking for a long time, making sure patients' medical conditions are optimized, making sure they're getting appropriate antibiotics, the skin is fully cleansed, their nutritional status is up to par. Do you do hip and knee replacements in 80-year-olds? Yes, all the time. Do you need knee replacement if the meniscus is the only part of the knee that is injured? No. If the meniscus is the only part that is injured, you can address that some other way. Had total knee replacement 3 years ago. They had to scrape the kneecap and add a button. Still have significant pain in the kneecap, especially going up and down stairs. What can be done? So it could be that the facet of the kneecap is still rubbing, that there's some scar tissue, or possibly the button is not covering the bone fully enough, and there's some abnormal friction there, so that can be looked at. I had severe left knee pain, but upon review, the surgeon said the problem was my hip. The problems from my hip were causing pain to refer to my knee. Since my left hip replacement, I have no knee pain. Is that common? Yeah, well, so yeah, I think I addressed this in our early question that we do rule out referred pain. Is there a maximum weight restriction? How soon can one walk up and down the stairs? Well, so it's not a weight restriction per se, but studies show that BMI can be a factor influencing success or complication rates. But there's no absolute cutoff. And then also there's, you can look at people will look at the newer generation weight loss drugs have really helped with this, and people are able to manage things more successfully than before. So we can certainly have that discussion, but there's no maximum restriction. Okay. Another question on hip surgery, and yes, we will definitely try to arrange another session. What anesthesia is typically used for hip replacement? Also spinal. When you mentioned elderly with regards to anesthesia, well, so truly speaking, people who have, so the mean age for joint replacement, let's say about 65. All right. People who are younger than that, traditionally, we're told that there's a higher chance that they would need another joint. So people in their 50s or early 60s. Once you get into your later 60s or 70s, the chances of having a secondary operation do go down. But with regards to anesthesia, it affects everybody. So it affects everybody. But in terms of anesthesia, the point I was making is that it's really the extremes of age. So people who are really young, infants, and young children, or people in their 80s who would benefit from avoiding general anesthesia. What type of imaging is done pre-op? Usually an X-ray is enough. Sometimes we get an MRI. About 7 months ago, I had arthroscopic meniscus surgery performed by one of your partners. Unfortunately, I'm still feeling pain, only slightly reduced. What is the typical wait time to feel as good as usual? It really depends on what was done with the arthroscopic surgery. So this is typically we'd expect people to be recovered from that in less time than you're describing. So hopefully within 2 to 3 months. I have a friend who had knee replacements on both knees, separate times. Her physician had her use a bike-like device that was delivered to her home. Yes, the ROM tech is available. That's something that we can arrange. Under what circumstances is a hyaluronic acid injection indicated? What is the success rate? So hyaluronic acid is given, usually we reserve it for when steroids have not worked. A cortisone shot has not worked, and that's because also it's an insurance requirement in a lot of cases to do cortisone before trying the gel. The success rate, it's not 100%. It's on the order of 60 to 70%. However, for people who it works, there's a lot of people who swear by it and say that it works much, much better for them than the cortisone did. Do all the doctors in practice now use robotics? Is it most likely that any surgery will be with spinal anesthesia? Most likely are most procedures mid-vastus approach? Yes. So most of the practice uses robotics, and it is most of the time done with spinal anesthesia and mid-vastus, yes. All right. Mr. Smith, talking about great job on 2 hip replacements. Thank you. We appreciate the positive feedback. Who should initiate the discussion of possible knee replacement, the patient or the doctor? Very little pain, but my doctor says I have advanced arthritis. Limitations in knee flexibility and inflammation periodically constrain my activities. Also, I have bowed legs. Does this influence my potential knee surgery? Well, if you have very little pain, there's really no place to improve on very little pain. However, if there's a fear that any minute now you could sort of like the last straw could be broken, then or there's a fear that you get to an age that surgery is less possible, then in that scenario, someone might counsel you to explore that possibility. If the bowed legs are causing you balance issues or possibility of falling, which is always a concern, then that could be looked at. All right, I think we're about out of time. I appreciate all these questions. I'm sorry I didn't get to go through all of them, but again, thank you for attending, and I do apologize for the curtailing of the discussion to knees, but I will be happy to do a hip one down the line. Thanks again, everybody.